Welcome, everyone. I'm Matt Buman, Professor and Director of the Precision Health Research Initiative at ASU's College of Health Solutions. And I'm delighted to join you today as the moderator for this first in a two-part series on the use of AI in medical education and clinical practice. My research background is in technology-mediated approaches, including the use of smartphones and wearables to promote healthy lifestyles. So I am excited to learn right alongside all of you from our experts today on how we can leverage AI to improve health outcomes. I'd like to thank you for joining our Health Talks webinar, brought to you by the College of Health Solutions at ASU. Our college works to address the challenges facing people and communities to stay healthy and improve their health and manage chronic disease. And these Health Talks are just one way that we serve the community with timely and relevant educational information that also provides continuing education credit at no cost. So now I'd just like to kick us off with a few quick housekeeping items. First, this session is being recorded and will be posted on our website at asuhealthtalks.com. After the panelist presentations, I will be moderating a Q&A session. Please submit your questions as we go using Zoom's Q&A feature and not the chat box. That'll help us to be able to manage those a little easier. And finally, you will receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, this must be completed in order to receive credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. So joining me today as our first panelist is Imon Banerjee. Imon is an associate professor in Mayo Clinic, Arizona, and a graduate affiliated faculty in the School of Computing and Augmented Intelligence at ASU. Her technical training is in computer science, particularly in artificial intelligence and data mining. Her research findings show that implicit bias in the AI model towards race across multiple imaging modalities, and her research goal is to reduce the AI-driven healthcare disparities by proposing model unlearning and adversarial biasing to reduce implicit bias learned by the AI models. She is collaborating with minority-serving institutions and centers, including Emory University and Mountain Park Clinics, to train and evaluate the AI models with diverse data sets. After Imon's talk, she will be followed by Dr. Nelly Tan. Dr. Tan is an associate professor of radiology at Mayo Clinic, Arizona, and a dedicated radiologist with a passion for integrating AI into medicine. She excels in harnessing data to unveil insights that enhance patient care and optimize clinical workflows. Driven by a love for intelligent software, she actively contributes to the development of AI solutions that simplify and enrich the lives of both healthcare professionals and patients. We are very fortunate to have both of these this amazing experts with us today as we explore using AI to improve medical education and clinical outcomes. So AI, as I think we all know, has the potential to really improve health outcomes while lessening administrative burdens on healthcare providers. But how do we mitigate problems resulting from increasing usage of AI, such as biases revealed in AI models that affect minority groups? So we're pleased to kick off this two-part session on the effects of AI across clinical practice and in medical education and its current and future impact on patients. And with that, I will pass it over to our first presenter, Imon Banerjee, for her talk on transformative power of AI in medicine and education, a radiologist's perspective.
Thank you, Matthew, for the nice introduction. Let me share my screen first. I hope you guys can see my screen. So my talk would be about the bias in AI, the cause evaluation, and how we can mitigate some of the bias. So let me give you a very quick and easy example of what we meant by bias. So this is a very famous algorithm. It's called correctional offender management profiling for alternative sanctions. So this algorithm was actually developed to predict risk score for the pre-trial release. And this algorithm is actually using the image of the offender and try to predict what are the subsequent risk, right? But the problem was this algorithm was trained with the California, New York data. So when we look at this algorithm particularly, we observe the fact that the algorithm is just looking at the skin color. So, for example, imagine this particular person. The algorithm predicted the person has a very low risk of subsequent offense. But actually, if you look at the ground truth, you can clearly see that the subsequent offense the person has is a grand theft, but the model is only predicting the low risk 3. And the risk score is between 0 to 10. So when you look at any African American image, you can clearly see that the model is predicting a super high risk, although this person doesn't have any subsequent offense. So that means that the model is not really looking at any kind of proper feature. The model is just looking at the skin color from the image and predicting high risk just based on skin color. And imagine like how risky this model is to actually use it for the pre-trial release, because this model is extremely biased. But it is not really the model's fault, because the model was trained on the data. Actually, the data has some sampling bias. Because of that, the model learned this particular bias. So let me show you another example, which is a very interesting example, and the healthcare domain. So this paper was released during the COVID time, and it's published in Nature. And you can clearly see that the model is trained on a very, very large number of radiographs to predict the COVID just from the radiographs. And it's also trained on multiple institution data. And then they try to do the testing from like external institution. And then they realize the fact that when they evaluated the model performance on the internal data set, the performance super high. The model was able to predict the COVID just from chest X-ray with 99% accuracy. Even radiologists were surprised that how the model can only, without looking at any other data, just by looking at chest X-ray, how it can predict with such high accuracy. And when they tried the model on the external data, they identified the fact that there is a subsequent drop in the performance, like very statistically significant drop. So why there is this drop? So when they tried to analyze the model through like different generative model, silencing map, then they realized the fact that the model is not again learning like very important feature. It is basically learning these markers in the chest X-ray. So these markers are from a particular institution which has a much more ICU patient with portable chest X-rays. And since those are like more severe patient, the model is just predicting the fact that whenever you see these markers and this kind of pattern in the end, you predicted those patient has COVID without looking at any other feature. So model is not even looking at the lung; it's only looking at those markers. So which is again like which probably works better for their internal test set. But of course, when you apply on the external test set, you will not have always these markers to identify that those patients are COVID patients. So imagine like how risky this model is actually when it applied in the clinic. So we call this kind of learning ability of the model, when the model identify a shortcut, it's called shortcut learning. That means the model is not really looking at actual data feature. The model is just learning some shortcut to make a good prediction, because the model only is interested in learning a cost function which is optimized. That's it, right? So it just learns this shortcut. And we have multiple examples in healthcare. You can clearly see that we have racial bias in pain, we have unequal treatment, racial ethnic disparity in pain management. So we have all these problems, but I think it's not the fact that the AI cannot solve it, but there are a lot of like bias in the AI model. So if we just categorize the bias in AI model, you will see that if we look at the AI development phase, so we start with the patient population, we collect the data, we develop the model, and then we finally deploy the model in the clinic, right? But so imagine like in that model development phase, the bias is introduced at different steps. The bias is first introduced when you collect the data. There are sampling bias, confounding bias, labeling bias. When you actually develop the model, like computer scientists or data scientists who develop the model, they also introduce some bias. There are feature bias, algorithmic bias. At the end, when you actually deploy the model in the clinic, there's also inference bias. That means the presentation bias, latent bias. So these data bias and inference bias is not easy to solve, because it really needs a lot of secure data collection. Like you have to be very involved while you are collecting the data. You have to collect the data from multiple institutions, and we know that sometimes it's not possible during the training phase. So our main motivation is how to solve the bias only from the modeling part, like just to provide some computational solution to solve this kind of like modeling bias. So while doing this, so we were developing a model that just for chest X-ray, simple model, we want to predict the diagnosis. When we started doing that, we see that whenever we train the model to identify the diagnosis, the model is actually learning the race. Even though we know that the race doesn't really have any correlation with the diagnosis. I can show you the data later, but there is no correlation with the diagnosis. But still, the model only learns the race from the chest X-ray. And this study was actually covered by multiple news medias, and I think this study provide a kind of like opposite message that we wanted to deliver, but we didn't want to deliver the fact that there is some kind of like anatomic significance of the race. But I think what we wanted to describe is that the model is learning this race feature as a shortcut to make any prediction. So we already know that there are bias in clinical studies. So while doing this kind of AI development without careful evaluation, we are actually increasing the bias even more, right? So let me show you an example that when we train different, these are just different model on different data set, so you can clearly see the performance on identifying different race. It's like superhuman performance. When we show these images to the radiologist, they cannot perform this performance. They can at least say max to max like 65 75 70% accuracy of what race it is, but most of the time it is wrong, right? So as you can see that the model is like 90% time is like correctly identifying the race. So again, when we are doing the pathology detection, when we are doing the patient re-identification task, still the model can predict the race with superhuman accuracy. So we thought that let's give the model some bad quality images. So we tried it with low pass filter, high pass filter. So look at the quality of the images, right? But still look at the model performance. The model still can identify with these bad quality images like 90% accuracy of identifying race. With high pass filter also, just with this kind of filtering, the model's performance is still like 90%, which was really surprising to us. Then we thought that like similar, right? Like there are probably some correlation between the race and the pathology or something that we want to identify. And it is not like only from chest X-ray. We observe the similar performance from mammogram too, also from knee X-ray. So all the X-ray radiation related modality as well as ultrasound related modality, we observe the similar performance. So when we try to predict the race from the body mass, we can clearly see the performance is pretty bad. When we try to predict the race because of the mammogram from breast density, the performance is pretty bad. When we try to predict the race from disease distribution, the performance was bad. We remove the bone density feature from chest X-ray, try to predict the race, but performance is still good. So we don't know what the model is looking at. And as you know that the deep learnings are getting better and better in interpretability, but still we don't have a proper interpretation technique. So this is kind of like unsolved problem. So we tried a kind of like latent shift technique to identify that. But as you can see that the things that are moving is actually where the model is looking at. So if you see that the Asian patient, the model is particularly looking at the shoulder and the neck region. For black African American black patient, the model is again looking at the shoulder region. For white patient, the model is looking at the heart and lung region. We show these images like this explanation to the radiologist, but there are no anatomical explanation that why this model is looking at this particular region. So this kind of still and kind of like unsolved problem, but we just know that the model is learning it as a shortcut. So this as a solution, as I was saying before, that we are particularly interested in the computational solution because we cannot explain that why the model is learning that, right? So the first thing that we tried is called adversarial debiasing. So we have a model, imagine like just a classification model where we have this predictor branch and we have a parallel branch where we are penalizing the model for learning any race information. So don't worry about the mathematical detail, but it's just like we don't want the model to learn race. So we are just like penalizing the model. And for that, we have a complicated model architecture, but that actually works pretty good. So when we do that, we have a skin cancer study where we have different types of skin cancer, and we have different types of like skin color from the data set. And we have two data sets, Fitzpatrick's and ICS. And we use Fitzpatrick's for training, internal training, and ICS for validation. And we want the model to not learn skin color, but learn the actual tumor information, if it is malignant and benign. But when we didn't apply any of our adversarial debiasing technique, and we look at what model is learning, we can clearly see that the model learned the separation between the skin color. Model is not learning anything, no malignancy, no benign, just learning the skin color. But when we actually apply those debiasing technique, we can clearly see that the model learning a space which is kind of mix of all the skin color. So model is not learning specifically any skin color. And that also we observe on the performance, that model performance was getting better and better on the external data set. So that's what we want. And also for the very extreme cases, when you have very pale skin color and very pigmented skin color, the model performance is getting better. So exactly that is what we want, that we want the model to perform better on the extreme cases and the rare cases. So that's what we did for the chest X study too, that we have different race and we have different types of disease, and we want the model to perform equally on all the race. As you can see, that this partial debiasing and full debiasing is our model, and our model is performing better than the baseline models on different types of race. Another interesting use case I wanted to show you is that we train the model on the white and black patient, and the model performance is of course good. And we test the model on a completely different population, which is a completely Hispanic population. As you can see that the model is still able to learn the breast density from the Hispanic patient without any training. We never include any Hispanic patient in the training data set. So it shows that by like putting a kind of like negative gradient of the model, not learning the race information, we are getting better performance for this model prediction for all the race. So since we were using race, so in clinical there is another problem, that is when we are talking about radiology, we have the contrast image. So as you can see that when you are talking about kidney, so we have non-contrast kidney and we have the contrast kidney, and we just want to make sure the model identify both contrast and non-contrast kidney. And even if the contrast has a kind of like variation, still we want the model to recognize a kidney with semi-contrast data, right? And we have multiple models. So first we mix the contrast and non-contrast data together and then train a model. Then we also try the segment anything model. And we also have a debiasing model where we are penalizing the model for learning the contrast data. And when we apply that on contrast city, you can clearly see that all the models are performing more or less good. A segment anything model performs good, but there are some leakage on the segmentation. But when we actually tried on non-contrast data, where the kidney contrast is, there is like no kidney contrast, we can clearly see that most of the model fails, but our model actually is performing pretty well. There is some leakage, but still it can be recovered. But the segment anything model, the leakage is much more, as well as this mixed model, the leakage is much more. So it shows that we, when we don't want the model to actually learn any confounding feature, we can actually penalize the model for learning that, and model learning can be better and better if we try to penalize that. So that is our whole idea. And I would stop here. If you have any question, please feel free to reach me on this email. Thank you.
Thank you, Imon, very much for that great talk. As noted, if you have questions, you may put them in the Q&A box, in the Q&A button, and we'll address them at the end of our next talk. So now I'd like to pass it over to our second panelist, Dr. Nelly Tan. Go ahead.
Thanks so much for having me. I really appreciate this opportunity to talk to you. And I'm going to start off. So I'm a abdominal radiologist. I'm going to touch briefly on my perspective as a clinical radiologist, and how it's kind of affected me in practice, clinical practice, as well as education efforts and research. And like I said, it's all just how, like, my personal perspective on it. So I love ChatGPT, and I'm going to acknowledge you here. And I want to kind of understand the audience. There's a lot of AI applications, and Imon is an expert in it. She's incredible. I'm coming more from a layman's perspective on AI and how it can help me, my life, and make my life easier generally. And one of them is I'm going to be touching on is large language model, which have become really important over this past year and has touched a lot of our lives, especially mine. So it's just you can chat it in or whatever. I see Justin Mitchell, he uses Chat GPT every day. All right, great. So it's if there's any others who use it, feel free to holler. But right, I will keep moving forward. So we're gonna, as I said, I'm a clinical radiologist, and we have the pro Imon here, who can give you more kind of the technical breakdown of why and how things work. For me, it's, how can I apply it in my life to make my life easier, to make those I support and mentor easier. I'm going to touch briefly about how it's used currently in radiology, in image processing and diagnosis, and the outputs that we get on a day-to-day basis. I'm going to highlight some examples that we have implemented in practice, and then I'll touch briefly on how I'm using it in research and education efforts that I'm part of. So here's a couple examples that we have currently rolled out on a daily basis. One of them is it's called opportunistic screening. So we, as a radiologist, I look at pictures every day, and pictures, there's only so much that we can look at, but now AI can do a lot more. One of them is called screenings, opportunistic screening. We go to the gym and exercise and build our muscles, and AI can measure that how big your muscles are. And some people, especially older or really sick people, their muscle volume surface area is very small, low. So that's called sarcopenia, when your muscle volume is smaller or thinner than normal for your age and gender. And it's a marker of frailty. And we know frailty in general is not good, right? So people who are frail, they have a much longer length of hospital stay. If they get sick, they have a harder time recovering from illnesses. Frail people have a difficult time doing kind of after surgeries or procedures or treatment, they have a much harder time recovering. And AI can now measure all of that and give you and predict, your severity of frailty, so that as a prognostic marker. Um, this is just one example. Another example is fractures. Older people, they can hundreds of thousands of older people, they fracture their hip every year. And oftentimes that fracture can lead to devastating effects and eventually their death, and cause a lot of morbidity and mortality. And so now, in the same way that AI can measure muscle surface area, it can measure your risk of getting a fracture, a bone fracture, for example. And I'll show you some other examples. In practice now, we also have um, we've trained AI to do these really painful, tedious tasks. So this is an MRI of the abdomen, and there's a condition called polycystic kidney disease, where it's a genetic disease. The kidneys and the liver, there's a lot of cysts. These are little fluid pockets. But the problem is that they can get really big and they can replace essentially your kidney. So patients need to get transplant because their kidneys they stopped working. And one thing that we use to measure progress is the volume of the kidney. So people who have severe disease will have massive kidneys, and we have to measure the volume. So before, we would go through each slice and contour the volume, which is so painful, right? You just, there's like 40 images and you have to contour each kidney, each liver, and you would spend an hour on it. Now we train the model so that it does it automatically. And this is an example of the contouring that it's generated, so that when I open the study to read it, I don't have to spend an hour, going through and contouring each liver and each kidney. It just spits out the volume, and I could just put that in my report and move on to the next study. AI can be used to predict risk of heart attacks and different cardiovascular events. So a really important one right now we use is called the Framingham risk stratification. So it looks at, for example, your family history of heart disease, heart attacks, diabetes, all these things that, smoking, that increases your risk of having a heart attack, which is, among the top three, like cardiovascular events are among the top three causes of death. Actually, number one, cardiovascular disease, second by cancer. So when we get a CT scan, we can look at the calcifications in a big vessel called the aorta that's in the abdomen. And you can see these kind of white spots. Those are calcifications. And those white spots affect all vessels in our body, including the vessels that go to the heart, called coronary vessels. And when those white spots, or we call it plaques, right? Atherosclerotic plaques. Some are calcified, some are not, but it's a marker of extent of vascular disease. And when they compare, we can quantify this. AI can go through and tell you how much calcifications you have in your aorta. So when they look at this, they find that AI's output of calcification is better than the current clinical standard of care, which is a Framingham risk stratification, to predict your risk of cardiovascular events. And so all of these things are currently available in our imaging studies now, that now AI, all these additional information that AI can extract to then predict a patient's likelihood of, getting fractures, or getting a heart attack, or getting, end stage liver disease, things like that. And now with large language model, of course, the best one on the market is ChatGPT, GPT-4. They can do a lot more now, and most of radiology or medicine is text. Everything is text, right? We write all of our notes in text. Everything is like text, and that's part of the problem, is trying to extract meaningful insights from all of this text. So as a physician, when I'm trying to review someone's X-ray or CT, I have to dig through all of those texts and make sense of it. And that takes a lot of time. And if you're short on time, or you're just really busy, you can miss really important information. And sometimes you won't see all that information because it's like in 200 pages of text, right? It's just not an easy way. And now these large language model can extract and surface all of these insights in a really quick and more effective way than we can do ourselves manually. And uh, multimodal LLM. So that means they incorporate different aspects. So this is in radiology, for example, one example of how you can use different models, right? So one model, for example, looks at the image. That's GPT-4V Vision, GPT-4V Vision. So you can upload images, and GPT-4 will tell you what you're looking at. And then another LLM will extract text data. So you combine different kinds of modes, and then you can synthesize it, which is what we're really good at, right? We can see, we can hear, we can touch, right? And all of these sensory feedback we then synthesize into whatever we perceive and make sense of. And that's what these multimodal LLMs are now capable of doing. So in radiology, for example, we look at both the images, text, and then we then issue a report that can then be reviewed by the doctor or the patient. Now, LLMs can do that. You have a model for the images, you have a model for the text data, right? And then they happen together to create then this report. Then that can be shared with the providers and patients. Okay, and this is happening now, right? Here's an example of in radiology how large language models are reshaping every part of what we do. The first part, clinical decision reports, like we can now extract information and data from the clinical history. So we have this AI assistant, kind of like GPT-4. It's called Maya, Mayo Clinic assistant that is activated. So now we can ask simple questions like, okay, give me a summary of this patient, and Maya will go in and extract the relevant data and then give you a summary. There's now abilities to auto protocol, right? Not here at Mayo, we haven't implemented that yet, but if you give information about why the patient is getting the X-ray, then the LLM can then say, okay, this is the kind of X-ray, this body part is what needs to be imaged, for example. And I mentioned briefly multimodal report, where you can use a model that looks at the images and another model that dictates or extracts the text to then create this new report. And then patients, right? Patients read it, and a lot of patients they're smart, but they don't have medical background. And so LLMs can now translate it in a way that is digestible and understandable to patients, and interactive way. So lots of benefits that is currently being used in practice, in my practice, right? It helps me read faster. It makes things more accurate, right? The volumes, for example, if a computer does it, it's going to be probably more accurate than me and more consistent. It automates tedious tasks that would otherwise take me a really long time to do, but now is much faster. And now it has the ability to predict outcomes data, like we mentioned, fractures, heart attacks, liver disease, end stage, kidney disease, things like that. So some caveats, it takes an infrastructure, right? Because all of these things have to be embedded into your existing workflow. That also ensures like privacy of patients. So, and AI is great, but it's not perfect. I mean, I'm sure those who have used ChatGPT know, like it's really good, but it's just not quite there. So when you really understands, when you understand a field very well, you can see all the errors that AI make. People who don't understand it will not be able to see it. So it's really important to know what is truth and what is not truth. AI gets close, but it's not quite on target, on par, and I'm sure it'll get better over time. So there's certainly misdiagnosis. It like it contours the liver, but then it actually includes the stomach, right? So that kind of thing. So, and I think we're better together, right? It's in collaboration with AI and human, so that AI augments, not replace human, because there's just too many errors that are high stake for it to go on autopilot. And basic understanding of clinicians, like what you know and don't know, is really important so that you maintain a level of independence. My daughter has GPT-4. I gave her a subscription. She's in 6th grade. And like what I've noticed is like because she's taking like chemistry and biology and physics, and she doesn't have depth understanding. So whatever GPT tells her, she just takes like 100%. And so when you don't have that fund of knowledge, it's very easy to just take whatever it outputs, and some of it might not be accurate. Like understand that LLMs are trained to make you happy. That's what I learned. So if you ask what's 3 + 3, it'll say 6, but you're like, no, it's not, it's 7. And if you keep telling it 7, next time you ask what's 3 + 3, it's going to tell you 7, because it's trained to make you happy. So like understand what its strengths and weaknesses are so that you know how best to use it in a way that's most effective. So and you have to maintain a level of independent thinking. So I'm going to now touch on education and research. And I'm going to share some of my personal experiences, how AI, like can really personalized learning experience. Like there's a lot of things I don't understand. So I'll go on GPT and start like asking, innovating, extracting, and ideating. And that's been really helpful. My colleague who is a specialist in women's health, she creates scenarios for medical students, and she works with GPT-4 to create scenarios and problem-based learning. For example, there's a workshop on um, home violence, right? So she said, okay, GPT-4, I'm doing this for medical students, and there's appropriate way to prompt it so you're getting the information you want. Give me a case scenario that, I can illustrate violence, domestic violence, and then it spits it out. So it can be used in a lot of different ways. And I'll touch on the specific example shortly. And then enhanced research. So AI LLMs, they can process mass amounts of data really fast, and now with GPT-4 it can do a lot more. And I use it now every day, and I encourage my medical students, my trainees, to use it to write papers, to kind of use it to improve their content, right? To modify it. And I mean, of course, you acknowledge, you use LLM to assist, but it facilitates things so that it goes farther. So here's an example that was published, and I've done this as well on GPT-4. So you here in this paper, like PIRATS is a type of classification for risk of prostate cancer, and it's a score from 1, 2, 3, 4, 5. 5 means you most likely have cancer. 1 means you have a normal prostate. And so you can download like 30,000 rows on the spreadsheet, GPT-4, and you say, can you perform some preliminary analysis and visualization? Consider Gleason 7, which is a type of grading for the aggressiveness of cancer, as clinically significant. And it uploads it, and then it starts to then create a preliminary analysis. These are all the images that it generated, visualization. So it does both analysis and preliminary visualization. And it's a great way to get started, right? Because it's fast, it's smart, and it's easy. And then it interprets it for you, right? It says, look, like as your PIRATS score gets higher, the risk of cancer increases, and other things. So this and Imon and I are collaborating now to, for example, extract incidental findings. A patient comes in with abdominal pain, but they have this nodule on their lung, and it turns out it's cancer, but the patient needs to follow up and make sure they get that treated, right, or addressed. And here we see over 1,000 patients a day, right? To try to keep track of all of those patients on a regular basis, it's you're just prone to error, right? I mean, to error is to human. So we need AI models to help, with incidental findings, or even like minor things like errors in our reports, right? Like grammar, typos. I mean, those things uh, uh, AI can help with, so that you're generating a really clear and error-free report. Or teaching, we're all in a teaching institution. Here we have training programs to train doctors to become certain specialists, like radiology. We have radiology residents. And so we teach them how to report or mistakes that we've corrected as the faculty, but sometimes we don't have time, or sometimes they're they're not here, right? Because they were on call overnight and now they're sleeping. So you can't really teach them. So what we can do is translate, for example, what they reported versus what we eventually reported. And GPT-4 or equivalent can take that and say, look, this is what was changed, and this is a learning point from your paper, right? Imagine you wrote an essay and your, mentor or faculty edited your essay. Now GPT-4 can say, look, this is what they edited and this is how I made it better, right? And it's now can be done in an automated fashion. So those are some of the things that we're currently working on to understand and potentially implement. We have in collaboration with Imon, she developed and her student developed natural language processing models that will extract information from surveys. So we get thousands of surveys every day across the enterprise from patients. And so the NLP triages it, it gives it a label. Is it a wait time issue? Is it like communication issue? And then if there are patient praises, it automates the process. So it takes the patient praises, shares it with radiology staff, nurses, techs, so it makes people's days. And that's been rolled out right now. We've done it already. As I mentioned, GPT-4 has like changed my life. Ever since I started using it almost a year ago. It helps me write and edit papers. Ideation is phenomenal for ideation. I use it now as my advisor. If I'm having kind of struggling issue, I ground it. You can ground GPT-4, to an expert. So, for example, if I struggle on conflict, right? Like pretend you are the most like coach, or let's say I want to play football. I want to play tennis, right? Like, how do I master this serve that I want to do? So I could say, pretend you are the best tennis player, or whatever, the best tennis coach. Now instruct me. And depending on who you ground it to, like if you have Snoop Dogg teach you tennis versus a tennis expert, right? You'll get completely different outputs. So you can ground it to expertise to then help you get to what you need, and you'll get better things. We do it now for research projects, as I mentioned, incidental findings, reducing errors and reports, communication, education, diagnosis. It helps now with the vision aspect of it. So conclusion, AI is here. It's in my life. It's in everything I touch. It's going to revolutionize healthcare, education, research. It's not perfect, but it's better, and we're better together. And one of the concerns I have is I'm privileged, right? I live in America. I have access to GPT-4. That costs $20 a month. But someone who's poor, most people don't have access to this thing. There's a concern like it's going to widen that equity gap, and hopefully with future advancements in learning, we can, kind of lift all boats. So I'll stop there.
Wonderful. Thank you so much, Nelly, and thank you to Imon for the first talk. We're going to go ahead and move into Q&A. And so if you do have a question, looks like we've got some really great questions in the chat, but please feel free to add them and we'll get to as many as we can. I'd first like to start with Andy Weiler. If you could unmute yourself, or Carl, you can tell him exactly how to do it so that he can ask his question. He has his hand up. And then I'll go to the Q&A. Okay, well, let me move on since there are a number of other questions, and we'll maybe come back to that. Maisa says, this is primarily directed to you, Imon, that she shares your concern about the impact of existing structural disparities and entrenched racism on our work in health research. acknowledging, as was pointed out by both of you, that AI relies on the knowledge that we as humans feed into it through machine learning. And so what are your recommendations from your perspective on how we can effectively minimize this bias?
Yeah, thanks for the question. It's it's kind of like a really unsolved problem, but there are some solutions actually that I was mentioning before. So these solutions that are provided up to now, we categorize them into three broad components. So the first component we call data-centric solution, where we try to improve our training data set so that we can reduce the bias on the machine learning model that will be trained on the training data set, right? So either you select the equal sample from all the confounding like subgroup that you want to like minimize the bias. For example, gender, race, you have to have equal amount of sample of the disparity from the all this kind of subsample, but it is not always possible, because imagine that you are collecting data from two institutions. You may have a race, for example, like I don't know, American Indian, that is not even present in those two institutions. So it is sometimes impossible to collect the data with an equal sample. So data-centric solution is always problematic. Then come the recalibration of learning, which is the last part of the solution, where we develop a model. When we move the model to a new institution, we have to recalibrate the model for that particular institution to reduce the bias only for that institution. So which is also difficult, because you can imagine that not always the developer have access to the new institution where the model will be applied. So imagine like the example of GPT-4, right? So even GPT-4, the developer doesn't even know who are the user, because it is so popular, it is in the hand of everyone. So they don't even know like who is actually using the GPT-4 and how they are actually using it. So in that case, the recalibration of learning is really problematic. And then there are some computational solution which is actually applied during the training of the model. I, as a computer scientist, I personally believe that the computer centric solution is a way to go towards reducing the bias. But again, it's kind of like a unsolved problem.
All right, well, thank you. And complicated question, Maisa, hard to answer, and many different answers. So Tracy has a series of questions, and so I'll maybe throw out a couple, and you guys can decide how you would like to address them. So first off, for Imon, I believe she wants to know, did the data sets contain atypical African-American patients, for example, healthy patients without identifiable disease and with normal BMI as a control group? And then the second question is, if you penalize the AI model for identifying race, what happens when you need to reintroduce race, say to do an analysis on just a subset based upon race? So I think both of these are directed towards you, Imon. So maybe you can attempt to address these.
Yeah, sure. So I think these are very important questions. So we also thought that African American patients that we got from Emory University, they have a kind of like high disease prevalence. Because of that, actually, our model are identifying the African American patient race so well, but it is not actually true. Then we only run the experiments only on the no finding cases, where none of the white, none of the African American, none of the Asian patient has any disease, but still the model can identify race. So it doesn't really depends on the disease prevalence, but it's really the model is learning something that we don't really know. We call it actually unknown bias, where we know that there is a bias exists, but we don't know what caused the bias. So there is another discussion topic probably for another day, but there are also some solutions that solve that kind of like unknown bias. So this is the first part of the answer. But the second part of the answer is kind of like very interesting, that when actually we want to reintroduce race for the analysis, how we can do that. But that is a good point, that when the model is equally performing on all the race, but we know that probably when we apply it in the clinic, there are some kind of like difference between for every race, the diagnosis or disease prevalence. But in that case, actually, the model can be analyzed on the subgroup. The performance may drop, overall performance, but we show in multiple experiments with this kind of debiasing, actually the performance improve for different subgroups, though the overall performance may drop a little bit here.
Wonderful. Thank you. I'm going to skip ahead to Wendy, who it's a comment, but I want to kind of flip it into a question for both of you to address. Nelly, you were giving the example, I believe, of your daughter that was, putting full trustworthiness into the results of GPT-4, right? So Wendy makes the point, well, what happens when provider might do that in a case, and, to the detriment of the patient. So just wondering both of your thoughts on, what's the risk of that? What is the current level of risk of that? What needs to be addressed for that to happen? I know, Nelly, one point you made was sort of bringing together, sort of this, both AI as a support tool for clinicians, but maybe if either of you have any comments on that particular issue.
Yeah, and I kind of alluded, it's a two-edged sword. It's a two-edged sword, and it's how we use it.
Mhm.
So if you are already a content expert, like I'm an abdominal radiologist, and I have the understanding expertise to understand what it's saying is correct versus not correct, close or not, right? I can judge it. But let's say you were talking about another area that I'm not an expert in, computer science, right? If you ask me a question that has something to do with some kind of efficacy and whatever, I'm like, okay, sure, that sounds good, right? And Imon's like, no, that's not good. So for sure, and so it has to be used in the appropriate context for the appropriate reason, and and you have to understand what your limits are. So if if I'm mentoring a computer science student and I'm using GPT-4, then I have to acknowledge it. Like I'm not the content expert, right? I can only share with you, but it's to kind of the limits of my understanding. If you really want a true answer, or in my case, if you have a question about something that's outside my specialty, this is what I think, but I'm going to consult my partner or my colleague who is a content expert to make sure that what the information that I'm sharing with you is accurate. And we do that now, right? Without AI's help. I'm looking at a bone lesion. I'm an abdominal radiologist, but I see something in the bone. I'm like, that doesn't look good. I will ask my MSK radiologist, what is this? Like, is this bad or not bad, or what's going on? So, and I think that's key.
Yeah, I completely agree with that. And one thing actually it's important to mention here, that particularly the vendors, because we have two types of AI product, right? We have one AI product that is kind of like built in the institution. So the radiologist or any clinical provider who is involved with that product, they have the knowledge from start to end. So how we curate the data, how we validate the model, how we develop the model, everything, because ask Nelly, like when we develop an AI model, we used to meet with the expert like regularly, like weekly, bi-weekly, so that they have a complete knowledge of the whole pipeline. But that is different when you're actually working with the vendors. Because when you work with the vendors comes into your institution, show you a product which looks very fancy from outside because they selected only a few data set that the product really works very well. And then you take that product, apply it on your own data, you'll see that you start seeing some performance difference. So you cannot really blindly trust that algorithm when you don't know how the model was trained, what data was used, how the performance was on different subsets. So it is important actually to ask the vendor these questions when they are trying to sell you the product, that how the model was trained, which data was used, how the model performance on different subsets. So if you are particularly interested in analyzing the racial bias or gender bias or socioeconomic bias, so ask them like how this model was evaluated on all these subgroups.
Great. I see a number of these questions are being answered as we go here. One of the ones that I wanted to bring up, Rich asks about how you choose, sort of gets at sort of how you choose different AI or LLMs that you're looking at, and asks what information would be helpful to evaluate different AI models' usefulness, as well as, I guess, their innovation, so to speak, or usefulness to innovate. In other words, are there other models, other data sets that are being used that you're using? And how do you characterize the quality of these different types of AI models?
Nelly, you want to answer or you want me to answer?
You answer because I'm answering the Q&As.
Okay. So
I got
actually,
through 11 questions, so.
Right.
Right.
So we call it as a pathway from the reproducibility to generalizability. So when you actually develop the model, you need to ensure that it is reproducible. That means that it has to have a performance on the internal data set. It has to have a performance on the external validation data set, right? That's called reproducibility. Then it goes to a temporal validation. Temporal validation means we measure the model performance in the temporal timeline to see that if the model has any temporal decay. Because imagine you develop the model on the data only from 2015, then you apply it on 2016 data, 2017 data, you will see that the model performance is decaying because there are some new data point introduced, something changed, some treatment pattern change, some guideline change, and you will see that the model performance is decreasing. So temporal validation is pretty important. There comes the generalizability part. In the generalizability part, currently there is a belief that you have a model, you validate on internal data, you find one institute, you find that institute and validate the model on external data, and that's it, you have the best AI model. But that is not true. When you do the external validation, you have to make sure that you include multiple institutions, you include multiple age group, you include multiple racial difference, as well as you introduce different country, right? Because for example, we developed a model for breast cancer risk estimation, which got very popular. But then it was a collaboration with MIT. Then we realized that, but we only validated on US population. So we cannot really claim that this is a best risk prediction model. So we have to collaborate with Brazil. We have to collaborate with Asia so that we have a risk prediction model that is validated on different racial and different country.
So Adewale asked a question, and Nelly, thank you for your response. I kind of want to bring the question for further discussion. So what do patients think when or if they find out that their diagnosis or treatment plan was in part or fully developed based upon some AI model? What is their, what are your sense clinically as to how patients view that? And do you feel like that's going to be changing in any way in the future?
I think it depends on the patient population, right? Like in Africa, they have no radiologists. There's like one CT scan for the whole country. We have 100 CT scan in Phoenix, right? So we're talking about access equity. So in that case, the patients don't care if it's from an AI model. Better AI model than nothing, right? And they have stacks and stacks of images that nobody can get to because they just don't have access to resources. We're in a first world country, affluent, right? We're privileged. In these cases, we have more than the minimum. We have so much more than 99.9% of the world population. So in our case, it might not make a big deal, right? But in the other 80% of the country that don't have access and that aren't privileged, like AI can make a huge impact, right? And just widening and kind of decreasing the gap.
So I can give you an example, exactly what Nelly mentioned, that this was my kind of like aspiration to work on this particular area. That the first project that we were doing on the disparity is actually about the preeclampsia on Africa. So you cannot believe that they have to walk, like the pregnant woman, like the full pregnancy, they have to walk miles and miles to get an ultrasound scan so that it can be read by a professional radiologist. And it is really a dangerous situation when you have a pregnancy and you have a risk of preeclampsia. You are walking miles and miles, and that actually solves their life a lot, because it's not like AI will do the diagnosis. If the AI can at least say that you have an abnormality, so you should go and visit a doctor immediately, that helps their life a lot. So it doesn't really, as Nelly mentioned, it doesn't really matter who is reading the scan. If there is any support for them, that is what is important.
Right. This is great. You guys are, Nelly, Imon, you're doing an amazing job of answering all the questions in this way, so everybody's getting a response. I want to go back to one of Tracy's questions. And she asked, can you give the AI model an algorithm to follow, like how medical students are taught to read radiology, EKGs, and large amounts of lab data? So essentially, I think what she's getting at is sort of, can you give it curriculum in a way that will then help enhance medical education?
You mean for training the model, right?
Yes, correct.
Yeah, so that actually currently it is very popular technology for large language model. that large language models are primarily trained on the web scraping data, right? And web scraping, we know that most of the data are right, but there are also a lot of noisy data. So model can learn from anything. You don't have really control what data the model is learning from, right? It can be completely noisy false data. How to control that? So for that, actually, there is a technique that is currently being very popular. It's called knowledge injection. That means that once the model is trained, you have some guidebook, some textbook, whatever you want the model to be expert of. For example, imagine like Nelly's abdominal radiology. She has a textbook. She can give the model the textbook so that model can fine tune the knowledge only based on that textbook. So that
oh, go ahead.
Yeah, sorry.
No, when you finish, no, I want to add to
and
it.
then the model, not like knowledge, particularly which is learned like falsely, they would be rectified with those kind of like knowledge guidance.
Yeah. So and LLMs are particularly powerful, GPT-4, because they have like, so Imon and like she helped us develop a lot of workflows for patient experience, and that was like so much back and forth, right? The model output, then we keep revising, improving, giving errors and feedback, and like there's like an iterative process so that we can get to the model to the point where it was doable, workable in practice. But now with GPT-4, you can get zero shot learning, meaning you don't have to train it at all. You just say, like, I gave it a report and I said, I'm a radiologist, look for errors, typos, and discordance. And it did it. It understood what the finding section went. It understood. So zero shot. So I didn't have to do anything for it to understand the prompt. And you can have single shot, right? Like GPT-4 will give you an output and you say, no, that's not how I want it. This is how I want it. And that's a single shot. So you just say it once and it learns and gets better. So the answer is yes, you can use AI model, and it's going to get even more powerful because these models come now with like the internet, right? As its knowledge that there's actually very minimal things that we have to do to now get it to a working state.
So I think we do have time for one final question, and this also comes from Tracy. And I think this is a really good one to close on. Outcomes data is often heavily based on sex and race because of the biases related to social determinants of health. So this is outside of the AI space. We know that so much of what we know about outcomes is sort of laced in this of biases related to sex and race. How can AI outcomes data be helpful in learning better about social determinants of health and overcome, Imon, you talked about how they're embedded in the AI, but is there a way to use AI to overcome some of these embedded structural race and sex issues to really uncover what the real driving social determinants of health are?
Yeah, that's again, like there is a very complicated question, and I will try to answer. And we had some similar project like that, because this is another like interesting project where we try to predict the person age based on their head city exam. So we just feed the model the whole head city, and we try to predict the age. And we can clearly see that the model is very good at predicting age for most of the patient, but some patient is making consistently an error. And there is like 10, 15 years gap. And we thought that, of course, there are some kind of probably Alzheimer or some other disease that is causing this kind of like age gap between the model predicted age and the actual age. But when we looked deeply, we clearly see that it is based on the social deprivation index, because it's based on where the patients are coming from and based on the social deprivation index. And we can clearly see that there is a huge gap between model predicted age and the actual age. So we know that this kind of social determinants on like kind of social deprivation index, this has a huge effect on the AI model prediction. And unfortunately, none of the EHR data, which is like electronic healthcare data that we particularly use to train this AI model, actually has a very structured representation of social deprivation or social determinants of health. You cannot even imagine even smoking, non-smoking, which is not really social determinants of health, but a simple factor which is still not properly recorded in the EHR system. So even if we want, we cannot sometimes include the social determinants or cannot do the analysis on social determinants, but that is the most important thing. So we go as close to possible as a social deprivation index, but of course it's just a proxy. It's not really the actual data.
So thank you so much, Imon. Thank you, Nelly, for these great talks. That is all we have time for today. So we'd like to encourage you to follow CHS on social media. You can see our social media channels below, so you can learn about more opportunities like this one. Our Health Talk series will continue, as I mentioned, with our second part next month. And of course, details and registration is available at asuhealthtalks.com. Thank you so much, and we hope you all have a great rest of your day.